All right, so now we're going to go to CPAP and BiPAP. So, I just said BiPAP. These are really the same thing as a ventilator. So there's two different modes, right? We're going to start with CPAP. I love this cartoon. Actually, I forget what it says now.
I'm sorry, Mrs. Johnson. He's gone sometime during the night. He simply stopped breathing.
Thank you. I'm actually at the distance where it's not quite bifocals and it's not quite regular reading glasses. So CPAP and BiPAP. We're going to start with CPAP. So CPAP, continuous positive airway pressure. This is a spontaneous breathing patient, so it's not PEEP. But it could be, same knob, same thing. But we're going to call it CPAP because it's a spontaneously breathing patient. So when we're talking about CPAP BiPAP, if you've seen patients who are, usually it's a machine on a stand, it's a hose, and it's a mask of some sort. This is not an endotracheal tube or a tracheostomy tube, although there are cases where you can do that, but we're talking specifically about with masks. So CPAP, there's a lot of different type patients. In the home, you're going to have a lot of patients who have OSA, obstructive sleep apnea. So as patients have floppy airways from being obese, or even some people just anatomically have issues with their tongue and tonsils, they block their airways. They fall asleep, they start to relax, they block their airway, and then they stop breathing. So we'll put those patients on CPAP, and all it is kind of like our PEEP on a mechanical ventilator. We take and we splint those alveoli open. Well, CPAP's going to splint open all the airways and keep the tongue out of the way and the soft palate and all those things. Keep the airway open so that they can breathe. That's all it is. So we probably have a huge population of patients come in here with their CPAP machines. I think the latest numbers I saw is about half of our, we probably have only diagnosed about half of our CPAP OSA patients. So it's a really underdiagnosed population, and that's important as we move into the critical care side of things. So what does CPAP do? Remember what we said with PEEP, same thing. We're going to increase the partial pressure of the gas in the lung, so it's going to increase that diffusion through the alveoli, the membrane. It's going to open up all those airways. It's going to decrease the work of breathing because we've opened up those airways. And so now the cardiac workload, you can get into some, it's going to decrease cardiac workload in some cases. There are some cases, especially if it's a cardiogenic pulmonary edema, where if you put them on CPAP studies, sure, they die. That doesn't mean we stick it on and they die right away. Just long term, they will die. Higher incidence of mortality. So there are some variations in that I wouldn't get too caught up in because it's kind of hard to figure out who those people are. So it's a spontaneous mode. Okay, BiPAP. So BiPAP is CPAP with a breath. So we have a continuous positive airway pressure, not PEEP, CPAP. And then we have PAP, positive airway pressure or pressure support. So this is all the same stuff that we talked about in our pressure support ventilation. It's a CPAP with a pressure support. This is CPAP with a BiPAP. So it's really the same stuff. It's just a mask, so they gave it a different name. And I think I saw in an article they do that just to confuse nurses. So EPAP is the CPAP, so we can call it CPAP, EPAP, PEEP. Let's see, what other acronyms do we have here? There's a whole bunch of them. So then the inspiratory pressure, we have our BiPAP, our IPAP, our inspiratory pressure, many other names. And this is what it looks like. So if you look at this, this is the exact same picture that I use for CPAP with pressure support. And basically, it's as a patient, we have our CPAP level, not PEEP, CPAP, because the patient's spontaneously breathing. Every time the patient takes a breath, it delivers a breath, and it augments. It's not a set tidal volume. We're getting a pressure. So usually it would be something to the effect of, and I think I have a, so usually, typically, we have a, you'll see physicians get comfortable ordering the same setting, like we'll say 12 over 5. So when they say 12 over 5, 12 is the inspiratory pressure, BiPAP, the IPAP, and then over 5, 5 is the CPAP. So we're basically that upper number, the point there, that would be our 12. So we're giving 12 with each breath, but each breath will be a different size depending on what the patient's doing. And then our CPAP level is basically continuous pressure to open up the airway and improve oxygenation. So complications to CPAP and BiPAP, there's another acronym, NPPV, non-invasive positive pressure ventilation. So we're full of them. So the complications are similar, but we can add aspiration. So, obviously we don't have the airway to protect the patient's airway from aspiration and things. So if you have a mask on a patient, if they have nausea and vomiting, we have to be especially concerned. Let's say if we have nausea and vomiting on an alert patient, maybe we're going to weigh the risks and benefits. But if it's an obtunded patient and they're throwing up, bad idea, because they will aspirate and we're going to have bigger problems. Air in the stomach is a big problem, so we may want to consider, do we want to do CPAP and BiPAP? Maybe you want to put an NG tube in to pull some of that air out. And skin breakdown. Skin breakdown is a real challenge, especially in acute care. If you have somebody where we're trying not to intubate them, we get hospice patients that we don't want to intubate because we're afraid we'll never get them back off again. We have our COPD patients that have had 6 exacerbations over the last year that we're afraid if we intubate them, never going to get them off again. So we try to limp them through with BiPAP. And you stick somebody like that on for a day, 2 days, their nutrition tends to be poor, so their skin integrity is not great. And we're putting this mask on and strapping it on. And in addition to that, it's going to be, as every breath goes, just watch somebody on BiPAP. The mask rides up and down, up and down, and up and down. And so that causes chafing. And then these people are really sitting ducks for sepsis if they get a sore. So it's a real challenge in acute care. Compliance is the other problem. We'll have a patient who we know that we can support this patient for the next hour or two while we diurese them, but they just will not tolerate that mask, and so we end up intubating them. And it's a shame. People get claustrophobic. It's very uncomfortable. If you have a stuffy nose and stick that thing on, it's horrendous. I actually wear CPAP. If you have a stuffy nose, it's horrible. But otherwise, it's awesome. It's dry gas. If you take a lot of flow of gas and there's not a humidification system on it, it dries you drier than you have ever been dried before. So it's very uncomfortable. And then some of these patients are just confused. So just sticking something on somebody's face that you can't explain what it is and reason with them is a challenge. So our biggest problem with any kind of rescue, they call it a rescue, is compliance and then source. And here's why. We have all these different interfaces. So the first two, the nasal mask and the nasal pillows, they tend to be the most, patients are most receptive to them. So one covers just the nose. It looks like a mask, almost like your resus mask. Covers just the nose. And then the nasal pillows, they're just that. They're like little discs that kind of sit right in the opening here. And so the patient's mouth is exposed. They can still talk and all those kinds of things. So they're a little bit more comfortable for patients. Downside is their mouth isn't covered. If they breathe through their mouth or they're hanging their mouth wide open, it may not be effective because all the gas will leak out instead of supporting their breathing. So in a patient like that, we'll typically move them to a full mask, which is that top right one with the red band. That's a full mask. They're very uncomfortable. You can't talk because everything's covered. If you work your mouth, the thing rides around. They're just not comfortable at all. And so that's typically what we will try to use on a patient using respiratory failure. So you're short of breath. You don't have a lot of patience as it is, and we're going to take and strap this thing on you. It doesn't work very well. One of the newer masks, and we actually just got these in for our pediatric population for the ED. So if anyone's in the ED, you may see these soon. And it's basically called a scuba, and it covers everything: the eyes, the nose, the mouth, and everything. So the idea behind it is you can see past it. It's supposedly a little bit more receptive for patients. I've tried them in the past with adults, and they hated it. But there's not a lot out there for the pediatric patients. Anyone who's worked in pediatrics, things don't get FDA approved very well. So a lot of things are done off-label. But we got some to try in our ED with some patients. So I think people get hot because you have this thing and you're sweating and it fogs up. So we'll see how it works out. You're going to see that these are both full masks, and you'll see a couple different ones. I'm pointing this out. Really, this is specific to this place. If you look at the one on the right, it kind of goes below the chin. So most full masks go over the nose and come across here. Ours actually go underneath. It has kind of a wraparound, so it kind of holds the mouth shut. And that's on purpose because we're in an acute care hospital. A lot of people are respiratory failure. And if you have it here, they can still sometimes hang their mouth open and leak. And really, we're trying to do the best we can to support that patient so they don't get intubated. So we have this that goes across the bottom to try to hold the mouth shut. Just so you guys know, as you're positioning these things, you know where it's supposed to sit. So these are the indications. We already talked about obstructive sleep apnea, hypercapnia. It's really about balancing. Like I said, we have some patients, we just don't want to tube them because we may never get them off. So this is an alternative to try to support them. CHF is a beautiful thing. You see somebody come in failure, you diurese them, put them on BiPAP to support them. It's awesome. You can see them, in a couple hours. You go talk to them, and they're through their crisis. So it works very well for that. There's a lot of studies now that talk about trying to get patients off of ventilators early, extubate them and stick them on BiPAP. I don't know that I totally agree with that, but there's studies out there. The whole idea of ventilating them until what got them there is resolved, we're sort of trying to push it a little bit. And if we have to re-intubate them, we're kind of backing things up another couple of days. So it's still kind of up in the air whether that's a good thing or a bad thing. Neuromuscular diseases, obviously we have patients who we don't want to put, some patients do get trached and they live with a trach. Pediatric patients, especially, pediatric patients have smaller airways. A lot of times if they have some sort of an airway issue that requires BiPAP or CPAP, they tend to grow out of it. So sometimes they'll basically use BiPAP, non-invasive type things, and hopefully they grow out of it. I talked about acute pulmonary edema and then to prevent intubation. So contraindications, a lot of these are relative. I mean, they list some of these as absolute contraindications, but they are all relative. Obviously facial burns, we don't want to cause things in, the masks, they tend to get sweaty and things like that. We don't want to cause infections and things like that if they've got open sores. If they've had recent facial or upwear, I think I'm missing surgery. Oh well, we're missing a number where there's supposed to be any kind of surgery to their face is a challenge. We just had a guy who he's an older gentleman, pulmonary disease, and we were trying to keep him from being intubated, and we were sticking him on CPAP. And nobody ever knew that he fell and broke his nose. And there were no marks, and so we couldn't figure out why this guy's flinching. And so we figured out he has a broken nose, and here we are trying to stick this thing on there. So it's tough. Inability to protect the airway, that's a bad thing. If we stick them on BiPAP and they can't protect their airway, an obtunded person on BiPAP really should be monitored at all times. Some people say that's a contraindication. I call it a relative contraindication because we have to weigh intubation versus BiPAP. I mean, maybe it just means we have to have a sitter with them. So it's just the way it is. If there's a lot of secretions, it depends. We have patients who are obtunded. If they have a lot of secretions, that's a bad thing. But we have patients too who can manage lifting the mask up and removing their secretions. So I would say that's okay. Impaired consciousness, severe confusion, agitation. I already said about vomiting. I haven't really seen too many allergies or sensitivities to masks, but I imagine it's out there. Nasal decongestion. So blowing in the eyes is a big thing that you hear people complain about. And I'll come back to that in a second. Cardiovascular compromise. I don't know that I've ever seen that, but it's listed as a contraindication or a complication. But it's up there for completion. I don't know. Pulmonary barotrauma. It's kind of rare to cause barotrauma with a BiPAP as well. But it's listed. And then abdominal bloating, that is kind of common. So now, two of the biggest problems I already said about skin breakdown, pressure ulcers, and compliance. They're our biggest issues. So when we do this, we need to make sure improving compliance is really about making the patient comfortable, and in hand that will also help with any kind of pressure ulcers. Our newer BiPAP machines, and unfortunately I couldn't bring one along because we have a very busy volume of BiPAP patients right now. They have smart technology that compensates for leaks. So when we put a patient on a mask, the old days, and by old days I'm talking 5, 10 years ago, we would put footprints on their chest, strap that thing tight because we don't want them to leak. We want to make sure they don't get re-intubated. These new machines are smart. They've changed how we do everything. We actually want them to leak now. So we'll hear all the time, oh my God, the mask is leaking. That's good. We want it to leak. We actually want leaks to a point. So if it's leaking a little bit, we like that because it means it's loose, especially that patient that's going to be on 3 days straight, and we're going to try to give them as many breaks as possible. We want that loose because if they hit the point where they start to get a sore that they can't wear it at all, we're kind of up the creek without a paddle. We got to intubate that patient. So we want to make them loose. The software can compensate for like 40 liters of flow. That's impressive. And then if you look at some of the masks, if we strap them too tight, we're almost bypassing what some of the design is. If you look, a lot of them have like a lip that moves. So when you strap it loose, the lip kind of comes out and seals against the face. So if you strap it tight, you're basically eliminating that. So we do want leaks. That's going to improve compliance. It's going to reduce the breakdown of the skin. Now, going back to the previous slide, I talked about blowing in the eyes. People say, oh, I'm blowing in my eyes. I can't take it. I wouldn't want that either. All you really got to do is, if we want the mask to kind of be parallel to their face, but if you need to just rock it a little bit this way so the leak is at the bottom instead of through the top, improves compliance, reduces the breakdown. So we definitely want to try to do all those things. So how do I know if the leak is too big? That's one of the things you got to worry about, because I can make that thing really loose and really leaky. If the patient takes a breath and it doesn't trigger a breath, I know that it's not working. It has to be able to trigger a breath. At the same time, you should be able to cycle the breath off. The way the machine works is the patient starts to take a breath, it senses it, it gives a breath. Then when they go to exhale, the machine should sense it and cycle it back off again. If there's too many leaks, they won't trigger, and they also won't be able to cycle it back off. So if you see them breathing and the machine is breathing with them, you know it's working well. Okay? Now there is one circumstance where you may see a patient take a breath and nothing happens, and it's not related to this. So going back to, we had talked about obstructive sleep apnea patients, and I said we've only identified about half the patients who have obstructive sleep apnea. The reason that's important is we'll have patients who come in, and let's say normally if we actually diagnose that patient, or even some of them have been diagnosed, and they wear 12 of CPAP at home. They come into our emergency department, we stick them on 12/5. So they need 12 centimeters of water pressure, open their airway at home. But then they come in here, we're going to put them on 5. So what that'll look like, it'll look like they can't trigger. You'll see their chest moving, and nothing's happening. It's not going to actually deliver a breath, because they're still obstructing. So that's one caveat to that. You'll see patients that have never been diagnosed with sleep apnea, but you can tell that they're obstructing. Even on BiPAP, they're obstructing. So we may have to turn that expiratory pressure up and kind of figure that out. So also preventing skin breakdown. We have a lot of issues with skin breakdown because of the nature of the device. So in addition to making it loose, we want to make sure it's the right size mask. And so hopefully we size it correctly. Sometimes we may have to try a couple different masks as loose as possible. We talked about that. Removing oil. I know you guys take masks off to give pills and things like that. If there's oil on there, clean it off, clean their face. What happens is the oil is, it slides around and it starts to chafe. And I actually just learned that as I was putting this together a few months ago. I never thought of that when I did patient care. I just said, hey, stick that thing on there. But the oils will actually make it slide around and cause chafing. And then once they get a sore, you're kind of stuck. Inspect the skin constantly. One of the things that we're really bad at is finding sores ahead of time and documenting it so that we can try to find a way to get around it. And then we also want to make sure we stick it on. There's some patients the doctors say, no, don't take them off. But we still need to assess their face, because if we start to get a sore, we got to get on top of it. We can't wait and then after the sore's been there for 8 hours, realize that it's too open to do anything with it. We can't wear a mask. Now we don't know how to support the patient. So we really want to make sure at least every 4 hours, especially if they've got poor nutrition. Those people, it's incredible how fast they can develop sores. So what we can do, another way to prevent skin breakdown is lots of breaks. There's a misconception that it's not like an ARDS patient you have on a ventilator. You take them off the ventilator, you're watching the second hand as they desaturate and try to die on you. Patient on BiPAP isn't going to be like that. We can take a patient off of BiPAP, give them a little break, maybe wet their mouth a little bit. Hopefully they can stay off for even longer. We have other things to support them with, high flow nasal cannula, things like that to give them a little break. So we want to try to convince the doctors, you know what, continuous is good, but breaks are better. So we should try to take them off for a little bit, even if it's for an hour. Give them a little bit of a break, give the skin a little bit of rest. We can try different masks, so we have different pressure points. We have skin barriers too. So I don't know if you guys are familiar, like a lot of the clean utilities, there's a wound care nurse cart. Has all the different products and things. So if you look, that thing on the bottom, it's like a little foam dressing. So we can use that. If we have a really bony nose, that's a good place to put those things to try to prevent skin breakdown. You clean the skin first, and then you put that on. And then we have this stuff I call lollipop. This stuff's been around forever. It's good stuff. If you have a spot that you think is suspicious and it's a little bit too big for that little pad, and I kind of prefer this over the other stuff, but you put this stuff on there and it really protects the skin well. It's amazing. So you basically put it on, you make sure you let it dry. You just kind of swab it on there. You let it dry. We check to make sure it's okay near the eyes, and they say it is. But this stuff really is phenomenal. My daughter, who is now 17, if she had loose bowel movements, her bottom would be red, like raw and cry. I put this stuff on there and it fixed her right up. It's incredible. Kind of off topic.
Did you have to reapply it again after each use?
Yeah, you know, it can't hurt. Really, to put that stuff on there, it's cheap. So I mean, we're going to wash their skin between each. If we take the mask off, we're going to wash it. So yeah, reapply. So, and then, you know, for some of the other, we just have to try to address them as best we can. Nasal congestion, you know, we can get some saline spray and things like that. Irritation of the eyes, I said we can kind of adjust it. If you look at a lot of the masks, they have like a little adjusting pad here, and you adjust it, and that changes the position of the mask. So we can kind of play with that and try to get it blowing out the bottom instead of in the eyes. Cardiovascular compromise, like I said, I don't know that I've seen a whole lot of that. Abdominal bloating, your NG tubes are good. Give some breaks and things like that. And the aspiration, you know, obviously we have to watch that. I think what we'll do now is we'll play with the ventilator. Is that okay?
Yeah, I'm going to videotape it too.
So I think what instead of you guys being, there's a way that you guys can move up closer and still be able to see. I don't know how well you'll be able to see from there.